Good evening, members, officers and members of the public. Welcome to this evening's meeting of the Health Scrutiny Committee. Please be aware that this meeting is being recorded and live streamed on the Council's YouTube channel, and I welcome viewers joining us online. Can I request that mobile phones are either set to silent or switched off for the duration of the meeting? I'd also like to remind members of the procedure for tonight's agenda. Should members wish to amend, remove or add additional recommendations or requests as part of as part of our debates, then they need to state and propose their recommendations at the appropriate time and seek a seconder to then confirm the recommendation. Members will then vote on the additional or amended recommendation as necessary. I ask all members to be mindful of this when preparing questions and comments to ensure that each item receives appropriate attention and scrutiny within the available time. Should it appear that the meeting will run past the constitutional meeting guillotine time of 9 p.m, then I ask members to propose and second a vote on whether to extend the meeting to finish the business on the agenda by a new time of whenever we decide. Thank you. We will now move to the first item on the agenda, so apologies for absences.
Thank you, Chair. We've had apologies from Councillor Lumsden and Councillor Brooke, as well as Shirley Plenderleaf. And just to note, Councillor Monday is present as a substitute. Thank you.
Thank you very much, Callum. On to item number 2, declarations of interest. Do any members have any any interest they'd like to declare? No? Lovely. On to agenda item 3, minutes of the meeting held on 18th of November 2025. Any issues with the minutes? No? Happy for me to sign? Can I get a proposer? Dennis, seconder. Helen, thank you. I'll sign them next time. And, all right, very quickly on to agenda item 4, general practice, performance and availability. The purpose of this report is to receive an update from members of the committee on GP performance and availability. Firstly, welcome to members of the Northamptonshire ICB, the Integrated Care Board, to the meeting, and I'd like to invite you to introduce the report.
Thank you, Chair. Next slide, please, Callum. Good evening. What I've tried to do is provide a bit of context, hopefully information that you've not seen before, so hopefully you find it informative. Starting with some performance information. Again, I think this is possibly the type of information that you don't often get to see, so hopefully the committee finds this useful. I also wanted to talk a little bit around patient satisfaction, as much around maybe addressing perceptions, particularly in Northamptonshire and the National Patient Survey. I then want to talk in a bit more detail about a significant piece of work that we are undertaking at the moment, which is around addressing variation in general practice. And finally, there are 3 elements that I just wanted to talk to regarding specific work streams that are taking place at the moment. The bottom one is imminent, but I think you'll find it again informative from a Northamptonshire perspective. Next slide, please. So hopefully, again, this is information that you're not used to seeing and you'll find it informative. So I ran some NHS England data with regards to GP appointments. The data sources are becoming richer and richer in primary care, which is really good, which I'll touch on later on in the presentation. But just for people's information, last year, general practice delivered over 5 million GP appointments. And on the tracking year to date, we are 3.2% up on that year on year, which is a really positive step. This isn't the case in all ICBs, and I know from a planning perspective, the general year-on-year increase is around 0.7%, so it feels like we're tracking above that, which is great. Also, just worth noting, October this year, or last year, this financial year, there were over 500,000 appointments in 1 month, which, to my knowledge, is the highest since records began, and obviously records haven't been going for a long time, but again, I think it's just worth pointing that out. As an ICB, we are often measured against other ICBs, and when it comes to GP appointments per 1,000 patients, we generally come out quite well and have done for a significant amount of time as well. Next slide, please. And this is just really just a graph that shows what I've just talked through, the year-on-year increase on GP appointments and the year-to-date activity as well being higher than last year. Next slide, please. The next 2 slides I wanted to talk to because One of the areas that NHS England manage ICBs or expect ICBs to respond to is the National Patient Survey. And the National Patient Survey has a lot of limitations in the uptake and the number of people that respond. And it's not something that correlates with the data I've just shown you for Northamptonshire. So certainly for the National Survey, we don't often come out highly. What NHS England are starting to bring into the management regime that kind of we're under is patient insights, which should be more informative and gathering data from a number of sources and not just the National Survey, which, and I realise there's a lot of colour on there. The colour that you need to be focusing on the left is the purple, which is Northamptonshire, which, as you can see, we sit somewhere in the middle of the 11 ICBs within our region. So it's just a bit of it's sort of a different information to what you might used to be seeing in the National Survey. Next slide, please. Similarly, these two indicators relate to preference of seeing a healthcare professional, which is obviously something that's significant with recent reforms in the GP contract. But also how patients knew their query was going to be responded to on the first point of call, and this is around patients understanding at their first contact with a GP practice how their query is going to be dealt with. And again, for that one, so we're again the purple line, and you can see that for the region we're just sitting second best, but we're consistently in the top 10 nationally on that particular indicator, which again, hopefully. I know that you will see the National Survey and what that tells you, but hopefully what I'm giving you here is some additional information that provides a little bit more context around patient insights. Next slide, please. This is where I wish I had a laser pen just to point. So I mentioned the work addressing variation in general practice. There's been a big drive on this year, and to support that, and this is where I referred to the data earlier on in the presentation, there's a lot more data for ICBs to review, more than there ever has been, in fact. So to support this, the national team launched the GP dashboard, which is what you see on the left. This has a lot of information that is now shared with us. It covers GP access and experience, it covers workforce indicators, it covers clinical indicators, and it covers screening and immunisation indicators as well. And hopefully, you might not be able to see there, is practices are given a score based on positive or negative variation. And we're able to use this to support that variation work. Now, on the right, you see a very small screenshot of the local dashboard that we've produced to support this piece of work. So the GP dashboard has a lot of data lines, but not all of them that we feel are important. So we've developed a local dashboard that brings in the national data lines, but it also includes a number of local important data as well. And that's constantly changing. So for example, again, you won't see it from here, but things like daytime 111 data is starting to feed in that. So what that tells us, if a practice has a high percentage that maybe things aren't quite working in the day and patients are either being directed or taking themselves to 111 rather than contacting the practice. Just for information, there's so much data on the local dashboard. We turn that into three sort of dashboards. So we have a priority 1, which has the really important indicators. We have priority 2, which has a set of important indicators, and priority 3. And the idea is that we're able to look at if people are high risk in any of those priority areas, but it helps us prioritise or target our resources where it's really needed. Next slide. So how do we use the data as an ICB? So as I say, there's an awful lot of data to pull through. We've set up an operational group which reviews that data. It gets presented in a different format for the committee. Because there are so many data lines, it wouldn't be a good use of anyone's time to sit and go through that data at that meeting. So what we do is we pick out practices that are flagging on the national dashboard and the local dashboard. And you can't read the information within the top right-hand corner, but that's our quick sort of reference as to where the practice might be flagging. So for that particular one there, you can't see that, but the red box in the left-hand corner is overall variation, and that's based on the national dashboard. The next one is GP access. The amber one is workforce. You can see the two clinical indicators are strong in terms of being green, and the last one is the risk score on the local dashboard. So we'll use that just to get a quick reference of of how a practice is performing. What we then do is we turn that into key lines of inquiries, so we extract that data down so that we can see what's flagging all those different points there. And it's from a positive and a negative perspective as well. And so we'll go through those key lines of inquiries as a group. We'll review the data. We will use any other local intelligence. But we'd also look at demographic information as well, which is that top middle slide as well. And we'll go through that and agree as a group what the key lines of inquiries will be for the practice. Following that, we'll contact the practice, so we'll write to the practice, we'll share the data, we share the key lines of inquiries, and we set out an action plan or a template action plan for the practices to return to the ICB within a period of time. The group will then go through those action plans and decide if there's any further steps that need to be taken, and if not, review and monitor the steps that have been highlighted in the action plan. If I can show you, next slide please, Callum. So, because there's so much data within the dashboard, there's so much information, I just wanted to highlight some of the areas where we're picking out variation, where we've contacted practices, and ideally where we're starting to see plans put in place. So, for example, the top 4 bullet points, what we're likely to see in response to that is recruitment plans. And often there's a reason behind it. We're struggling to recruit. Fine, if you can share your recruitment plans with us, is there any help you need? Some of the clinical indicators, we can directly bring that back into the relevant team within the ICB and ask for specific support with regards to things like immunisations and screening. For patient survey, this is a really interesting one. So despite what I said about the patient survey previously, it's front and centre within the dashboard. It can't be ignored. It needs to be used. So what we're looking for from practices there is what local surveys have they conducted, what plans are they putting in place to try and address the patient satisfaction scores. And what we're starting to see back is local surveys that replicate the national survey but with very different responses as well. And of course what we need to understand from that is who sees those, who do you share them with, how many do you get back as well. So what we're hoping to see over the next 12 months is some improvements in a number of those indicators, obviously at practice level, but we'll start to drive improvements from an ICB perspective as well. Next slide, please. So here I just wanted to talk to 3 specific pieces of work that are taking place within the ICB at the moment. The first is the Utilisation and Modernisation Fund. So this was a national capital fund to support small changes within general practice to increase capacity. So from our perspective, we were very lucky. We had a very hands-on approach to this. We were able to get 28 schemes approved by NHS England. I don't know if it was the highest, but if it wasn't, it was certainly very close to being the highest. The team took a hands-on approach. As you can see, a lot of training has taken place from a practice perspective. And the outcome of that has been 20 applications that are now going through a process. So several have dropped out for a number of reasons, change of partnership, change of circumstances. It's to be expected. But the 20 are going forward. What the kind of programs of work that are taking place there is reworking admin space, splitting meeting rooms, working areas. What it means is we're getting additional clinical spaces in all 20 of those GP practices, which is a really positive piece of work. Next slide, please. Similar piece of work that the ICB is driving itself is the optimisation review. In some respects, it's a similar piece of work and it complements the utilisation fund. But this is around a team of ICB colleagues visiting a GP practice, looking at room utilisation, understanding how the practice is being used, understanding how technology is being used, and then looking at ways that the practice can better use the space. Now, the good thing about this piece of work, and if we, again, take a look at the last slide, what we're hoping this does is it gives us a position where we have initiatives ready to launch once capital funding and if capital funding becomes available. We've seen a direct link from the optimisation reviews and the UMF from the previous slide, which is great. And what we're hearing from, so 12 practices have undergone this so far, what we're hearing is it was really informative, it was eye-opening, and it enabled them to get a different perspective. What we're struggling with on this particular piece of work is some people see it as us coming in and doing other things, so really having to manage that in terms of the optics of it. That is a very supportive piece of work. not to be used for any other reason than really looking at bringing capital programmes together for the future. And then one very specific piece of work for Northamptonshire is the same-day access early innovator site. So the ICB is piloting same-day access models within primary care. This very much links to the medium-term plan and is trying to get ahead of the national directive on neighbourhoods and same-day access hubs. An expressions of interest was sent out to all of primary care, and 2 were selected. One is in the south of the county, and as I say, in Wellingborough, we're really lucky to have one of those models starting to work through how to become live by the 1st of April. Next slide, please. So really what this just talks to, and there's 2 elements to this. The first is a same-day access model. So this is around increasing on-the-day access to services for urgent or on-the-day type presentations. You can see in there's some really specific information with regards to additional appointments, which is fantastic. But what this is about is freeing up capacity within general practice to better manage long-term conditions. So you can see the focus for this particular area is minor illness, mental health, MSK, paediatrics, women's health. So they have highlighted those areas as particular challenges from an urgent care perspective and targeted their model towards that. If you can go to the next slide, Callum. So what that does is enables primary care to free up more time to deal with long-term condition management. So that's what we're hoping. What we don't want to do is put more urgent care activity in and not get anything back from it. This is very much around supporting general practice to move some of that urgent activity into a more centralised economic position, and therefore freeing up capacity in general practice for long-term condition management. And again, as I say, this particular same-day access hub is looking at older people, frailty and multi-morbidity, as well as end of life. Again, that's something that they, as a locality, has highlighted as a clinical need for them, and that's what they're focusing on. So this is hopefully going to go live on the 1st of April. It's one of 2 pilots. The long-term plan is to review how these pilots work, if they're successful, and if they are, look at rolling them out across the county. Next slide, please. I think that's everything. Thank you, and I'm going to move back, but I'll take any questions.
Thank you, Kieran. What I'll do, actually, before I open the floor for any questions or comments, I'll address the elephant in the room first. What happened in October?
With the data?
Yes.
I think October is a particularly high month anyway. So, for example, when I reviewed the data the year before, October was also a high month. So I think on the calendar, it's just a month where primary care sees a lot of activity. I don't believe the data includes COVID or flu immunisation, so that might be the thought, but I think it's not included in that data. So I think whether it's a post-summer holidays thing, but it's just a seasonal trend.
Thanks, Kieran. I'll open the floor now to members for questions and comments. Councillor Monday.
Thank you, Chair. So we can see from the report that GP appointments are up across Northamptonshire, which is clearly a positive. Very good. Looking at Wellingborough specifically, including practices in my ward, I've written down the code here, K83601. It's probably going to mean nothing to you, but shown on the new models of care map, how do you know that this increase is actually being felt by local residents in terms of getting an appointment and seeing the same clinician rather than just keeping up with rising demand?
So we'll say it's not live yet, so it goes live for the 1st of April. And one of the things that we need to ensure, or one of the things we need to do as an ICB is to absolutely make sure it's additional activity. So the rich sources of data that we now have enables us to sort of track where these practices were at a certain period of time. And what we're hoping to see is that stays exactly the same or increases on the trend that it is at the moment. But we also see that additional activity within the new neighbourhood as well. Does that answer your question? Yeah, thank you.
Councillor McLean?
Thank you, Chair. A few questions which will be added together here. The number of appointments, 5 million, are they individual appointments, or could they be for a single patient who's maybe had 3 or 4 appointments? And the other thing, the other couple is as well is appointments. When people are given an appointment, they're sent to a private entity, let's say the Woodland. Are these included in these figures? And how do you deal with non-attendance at the moment of appointments? Thank you, Chair.
Okay, so the first question, it's an individual count, so it's every specific. So if a patient has one appointment one week and another one the week afterwards or later that day, it's counted as 2. Woodland isn't included, so it's just the 65 GP practices that we are contracted, or contracted with us. Sorry, what was the third part of the question? Yes, so we get data on DNAs, and so going back to the dashboard, it's something that it wouldn't necessarily flag on its own right, but as we start to work through practice and address variation, we're going to move or at least complement it with some other trends as well. So, for example, at the moment, online consultations is quite topical. A big one for us will be appointments per 1,000 patients. The idea there being that a practice that may be doing 600 per 1,000 patients versus one doing around 300, you can see there's a slight difference, a big difference there, and the kind of thing we need to address. And DNAs will come into that as well, so potentially we might look into it in more detail, but it's certainly something that we can report on and bring into that local dashboard.
Chair, can I just ask one more question? You say here in October 2025 that the highest single month for appointments. What operational pressures did this place on the practices? And if that was the highest number in October, did that mean that other months did less? Thank you, Chair.
Yeah, so the slides tend to show those sort of seasonal ups and downs. It depends on things like how many weekend days there are, if there are bank holidays, days in a month as well. I think it's a really difficult thing to... It's a good thing, as a councillor has pointed out, that the figures in some cases are going up. But I think there is a question mark as to whether it's sustainable, which goes back to the point around looking at different ways to do things. Historically, GP access was informally measured by a Tower Hamlets project that took place in 2008, which was trying to address what is technical access, which is how many appointments do you need to put on to meet the needs of patients. And that particular figure said, well, it's about 72 appointments per 1,000 patients per week, and that's based on a patient having about 2.4 appointments per year. That was in 2008. Now, it appears more that patients are being seen more than that 2.3, 2.7. It's probably nearer 5 or 6. And you don't necessarily see the contract funding going up with it. Do you see what I mean? So it's difficult to continually want to increase the activity, because the question mark is it sustainable, and does it need to drive some contractual reform to support practice in doing that additional work? Hopefully that makes sense.
Thank you very much. Thank you, Chair.
Thank you. Councillor Howes.
Thank you, Chair. My question's around repeat visits. You confirmed that Councillor McLean's question about the fact that it's the 5 million is one appointment, and it could be for multiple appointments for one patient. So firstly, do you know within a given time period of how many patients are returning for potentially the same issue, and are there markers in place to look at that? Obviously, I appreciate healthcare is not straightforward, and people obviously need to come back more than once, but I just wondered if there was any data on that sort of thing.
Good question. So no, not from an ICB perspective, but having said that, practices will have that information. So, and I would, going back to better management of long-term conditions, I would expect that to be one of the the outcomes of that piece of work, where a practice is given the time to review that kind of data and say, okay, so this guy's been in 3 or 4 times for the same thing. We need to spend more time and focus on this so that we avoid that in the future. So we're hoping that's one of the benefits of the new model of working. It's been something that's been looked at in the past. I can remember sort of 10 years ago where practices received data on what were called frequent flyers, so they could look into that. I think it's more about how maybe the neighbourhood framework going forward sort of starts to bring that into the mindset of practices that might not think that way.
Councillor Harrison.
Thank you. So, looking at your page on the Utilisation and Modernisation Fund, I think it's possible that one of the practices in my area has benefited maybe in the past from this, or at least from some work. So that's the Oundle practice. So I know that a few years ago we were getting a huge amount of complaints about people not being able to get appointments, and it was, it was really seeming quite acute. And I think that the ICB worked with the practice to utilise the building much, much better, make use of every bit of space and every bit of time that space could be used. And then there was more of an issue around not having enough staffing, and then that improved. And in the last meeting that we had about the issue, they were even looking at what other buildings in Oundle might we be able to use to expand even further. So, because, once the building is being used to its maximum, there was still some capacity issues. So I have seen myself that the surgery in Oundle has improved massively over the last few years. And I guess, if you're working with a surgery where, they're prepared to put that work in and listen and take the advice, that's really helpful. I guess perhaps it's not that easy with all surgeries, because there's still quite clearly, as you're talking about, quite variation between them. And I know of one that I would probably consider it doesn't really use its facilities that well. Do you find that some surgeries are more difficult to work with than others?
Thank you. Good question. Yes, I think the reality for us is there's 65 practices all operating under what is a difficult contract to implement at the best of times. And if you take the variation work that we're carrying out at the moment, we've written out to a number of practice on this matter, and the responses we've received have been really positive. Thank you for the information. We were aware of this. We're taking these steps, or thank you for this. We're going to look at doing something different. The reality of it is we're going to come across a practice that says thank you for this, but we're happy with what we're doing, and we're not going to change. And it's quite difficult to then enforce that change, I suppose. So I like to think that the team are generally supportive. I think the team have the tools to support, and we just have to continue at least knocking politely on the door and trying to bring people around. Maybe what neighbourhoods will do moving forward is bring a bit of that peer pressure in as well, around making those changes. But it's just like anything. There's 65 practices. They have different models, different approaches, very, very different senior leaders at the front taking things forward, and also different patient groups as well. So it's one of the harder pieces of our job to really try and bring everyone along, and that's what we have to do. And I think the variation work is the key to that going forward.
May I just also add to that? So we talk a lot about neighbourhoods, and I think that general practice in general feel under pressure, and they feel rather criticised. We hear lots, some of it's reasonable and some of it's not reasonable, but everybody has a perception. So the general practices do feel under pressure, and that's a double-edged sword for them, but it is also an opportunity. So especially linking in with things like family hubs and children's and everything else that you're all doing, which is neighbourhood is not just about, neighbourhoods won't be just about your GP practice or whether you can get an appointment or whether my diabetes gets checked when it should and so forth. It's about so much more than that, because many of the appointments are taking up, and it's not just those with long-term conditions, it's people with problems in their lives. They go to see their GP. If I was sat next to a GP now, they'd say a lot of what comes in is nothing to do with health, it's to do with their economics, it's to do with their family background, it's to do with their children with special needs, it's all that stuff. And so I think what we're trying to do is link everybody in. Wellingborough was successful as an early adopter, partly because of their ethos, partly because we feel that they can do it, they met the criteria. Those outcome measures that will be met, because we've put money, and we're all under financial strain, aren't we? But we have found money to put into the innovator sites for proof of concept, so that Wellingborough, when it's a success, will be able to say to other GP practices, look, it's so much better because we can see the patients that we need to be seen. Other patients that another clinician can see are being seen over there the same day. We're not getting criticised. You're not hanging on the phone for 40 minutes and you're 27th in the queue. All of those things has to make it better for general practice. So we're marketing it, I guess, in a different way to say more of the same isn't going to do it. So let's just try and do it together and do it as wider than health. Because we're not the experts in everything. We might like to think we are, but we're not. And there are lots of things happening out there that we really need to jump on the back of. So we're hopeful. But Kieran was being very polite. There can be some properly awkward people out there. We just need to bring them on and show them this is the best way to make your working day better. Thanks.
Thanks, Eileen. Councillor Duffy?
Thank you, Chair. Going back to the figures you showed for October and there being a spike in the number of people, my initial thought, and I guess from a couple of other questions, the initial thought is, why are more people sick in that month? But do you gather data on the availability of doctors and medical staff? In that if medical staff are taking their holidays in the summer and are not taking in October, can you facilitate more appointments in October? Does that make sense?
I think what we're seeing from the data is more the ability for primary care to react, I think is what I would say. So if, there will have been an element of planning within there, including, sickness and holidays and practices are pretty good at rotating well in advance to pick up the expectations in terms of staff being there or staff not, and an element of the seasonal trend. But I think there's an element of this is that if there's a particularly challenging period, the practice will see what's coming forward, if that makes sense, as best as it can. So I would suspect that some of it will be planned out and they would staff accordingly. I suspect a lot of it would be additional hours to make sure that the additional activity is seen. Going forward, we're trialling... it's not an OPEL programme, but it's part of the surge work that's done by ICBs. Primary care is traditionally hard to bring into that, but what we're trialling with, I think, 5 practices is trying to pick up on some of the clinical trends that are happening at that particular time. So, for example, in October, if that data was available then, was it a spike in respiratory conditions that were taking place in general practice that then secondary care saw 2 or 3 weeks later? So what we're hoping is it helps inform the wider system what might be happening 1 or 2 weeks down the line as these presentations get more serious.
Councillor Geary?
Thank you. I've got a few questions. The survey data that you've had feedback on, what's the lead time between collecting that survey data and implementing any information that you receive from it?
So the national data that I've spoken very highly on is once a year, so it's very difficult to see any real change. The insights data, I'll be honest, I'll have to take that question away. I don't know how responsive it is. It's every month, I believe, based on the narrative within the data. So I think it's a better way of reviewing where we are. So what I'd like to see, I suppose, is a more immediate response in that data, even if you don't see it in the national data.
Okay. Second question is on priorities, and you displayed in colour good, bad and different in your talk with the relevant medical practitioners about those many attributes that you had. I counted about 20, there might have been 22, 23 on that slide. So we have priorities as an NHS, and you also mentioned that you are dealing with people that have their own particular priorities. With that number of different priorities and different practitioners, how do you marry those two up?
So I think, to be honest, at the moment, the priority is very much around access. So whilst the rich sources of data we have there is fantastic, the expectation is we're really prioritising access at this particular time. Moving forward, and this isn't based on an assumption that access is being fixed, but if the work has been done on access, I think it's a decision for the ICB, for the operational group, to understand what the next priority might be, whether it's clinical indicators, whether it's the immunisations and screening. But as I say, the directive from a national perspective is very much around driving access. Now, I think mistakenly what the national team are then expecting to see is changes in the national survey as an outcome. I wouldn't expect that, to be honest. I don't think, to be honest, there's a great deal of correlation between the access that's happening on the ground and the national patient survey. Yeah, absolutely, that's the priority. I hope I've answered that adequately.
Yeah, I think I can see where we're coming from in terms of surveys. The first question I want to ask is on increased demand. Yes, we have population. We potentially have people are more demanding. We have an older population, and also an older population with multiple issues to be dealt with. I wonder if you can give me some commentary in terms of, with that increased demand, how each of those segments contributes to that.
The segments within the sort of scoreboard that I showed you. I don't know that I could answer that here and now. What I like to think is the neighbourhood work, the population health management focus that would come with that, the approach taken from a GP practice, a PCN or a neighbourhood would be driven by the needs rather than that piece of work there, if that makes sense. I don't think that's the aim of that piece of work, if that makes sense. It's very much around trying to bring people together on an even keel, considering those elements. But I think the neighbourhood work and the clinical strategies within the practices themselves will be what focuses more on the specific needs of their locality.
If I may add to that, so one of the priorities, so we've got a basket of priorities next year. We're in our planning round now for the ICB, one of which is frailty, another of which is children and young people, and then mental health and learning disabilities. We've had an Ageing Well programme going in the county for a good some years now, and it's seen quite a lot of success. So for the last couple of years, we've not seen an increase of admissions to our local hospitals of over 65s, and we've seen a decrease of over 85s. There's still masses of work to do, and frailty isn't just older people. Younger people can be frail as well. But working with, and as Kieran's just said, with our general practices, our local hospitals and our voluntary sector and our social services colleagues, we're trying to knit together an offer which means that people stay well and independent for longer, because that means that they'll be less, they will not tip into crisis as frequently or as often. And because we've been going for a few years at this, and we've put quite a lot of investment in over the years and have been able to demonstrate success with that. And it's not all medical stuff. It's befriending, it's balance classes, it's all sorts of things which are not health related, but they're good for people. And that isolation is taken away. So I think that the offer is there across the whole county. What we want to do is build on that, because we can put more hospital beds in, we can have bigger teams that go into hospitals to try and pull people out again. But actually what we want to do is stop people from going there in the first place, to be able to stay at home for as long as possible. And it starts right from when children and young people, because we know we've also got a young population, particularly during and post-COVID, who are in some real difficulties with neurodiversity weights and so forth. So we're trying to, especially in a period of change for the ICB, we're trying to just say, okay, what are those really big bets that we need to concentrate on, because we could try and boil the ocean and do a little bit of everything, but actually what we need to do now is really focus down so that we can see that shift from into that preventative arena, and that we're not always waiting until somebody becomes sick or go into crisis before we do something. So I think we've got some successes. and general practice has been a really big part of that. We need to bring people further along because there's quite a lot on offer. We want to put all our efforts into that, not just, I'm sure if my acute colleagues were here, David would know this, that they would say we definitely need more beds. We may well do, but we don't want to do that for the sake of not doing something else that might stop people from getting there in the first place.
I'd just like to talk about the early innovator site in Wellingborough. If you could you be specific in saying how long is left on that trial, and if it's successful, how long it would take to roll that out across Northamptonshire, please?
The innovator site, so they don't go live until April. Is that the question? The two innovator sites. So there are two, one north, one south. They go live in April. We've been probably 18 months in the planning to try and there's been an expression of interest process and lots of things that have gone on prior to that. There is no plan to stop anything that is successful. So we're hoping that this is and the reason why they're innovators is because we want them to innovate and show the rest of the county that this is the way forward. The way we've done it, as Kieran mentioned, we weren't entirely prescriptive about what those neighbourhoods wanted to concentrate on for themselves. We use the population health data and all of our informatics and everything, all that stuff that Kieran's talked about, disease incidence and so forth. So that Wellingborough, for example, and we put up what their priorities are as the local experts to say we think this will make a material difference to our local population. So making the assumption that that is a success and two counts, even if it's just same-day access and people with long-term conditions have a properly balanced approach and the touch points that they need from their healthcare professionals, that will be success. And so this isn't a pilot that we plan to roll back because we thought it was a great idea and then we went off it and went on to something else. This is something that we plan to do over the next few years, that we bring the first two on. Next April, we want to bring the second two on, so that's 4. We've got 9 in total. So we'll just keep bringing the innovator sites on. It's not an inexpensive thing to do, and so therefore the reason why we have to prove that it works is because we will have to shift money around ultimately. So 2 now, 2 in April, and if everything's hunky-dory, we'll keep going 2 by 2, as Noah said. Okay.
David, go ahead. We've got Q as well. We've got Dennis and then Mark and then Lee, but go ahead first, please, David.
Thank you, Chair. It's just really important as well to recognise that this wasn't starting from a standing stop in that sense. There's been lots of work in prior years around local area partnerships which match some of these new model of care neighbourhood footprints in that sense. So we've already got some really good groundwork in place between the NHS and other partners to sort of get us ahead of the curve with that.
Councillor McLean.
Thank you, Chair. Reference the NHS app. Do we know how many appointments have been booked through this? I mean, my surgery, they use the Accurus system to book or to get through to them. I find it excellent, actually, but my wife hates it. But do we know how many people are using the NHS app? Thank you, Chair.
Yeah. So all of the elements of the NHS app, we can run data on that, bring that into that piece of work we've just mentioned there. Going back to some of the work that will no doubt start to take place alongside the variation is that's very topical, and there'll definitely be a focus on NHS app usage, online consultation usage, as you've just mentioned, to try and drive up that kind of activity. So absolutely we have the data. It will become part of that piece of work that we mentioned earlier.
Just a quick one, Chair. I mean, I can understand that. I mean, and I can also understand why people may be reluctant to use it because they're sort of self-diagnosing to an extent. But I think, using the Accurus system, if you can give a reasonable account of what your problem is, then generally for me, I've always really had an answer within, or a call or something, or a text within a couple of hours. Thank you, Chair.
Thank you, Councillor McLean. Councillor Pengetly next.
Yeah. A lot of good work here. And what we're looking at is GP performance, yeah. But what we seem to be having is just the performance for the whole of Northamptonshire. And we can see that some of the figures, it shows England's flatlining in relation to appointments made, where Northamptonshire's going sort of up and down a bit all over the place. What we need to do a little bit more of, and I know it can't be done tonight, is look at more detail in where the issues are, who can get in touch, because my wife goes mad because I phoned up we're going straight away, Mark, because I've got some health issues, but I know there's people that can't use the apps, they can't get through to people, and they're the people that we, as members of the council, should be looking at. Why can't they get in touch with us? And mainly people over the age of 60, of course, but there's a lot of younger people that can't get in touch as well, and that's what we have to look at. We've got to look at what surgeries are doing well in bringing people in and what surgeries aren't. And I know myself and Lee on Facebook, we've tried to get through onto Lakelands and we can't get through to them, or we can't, we're trying to get to Forest, we can't get through to them. And when you look into it a little bit deeper, they can. But it's just letting people know how they can do it and how they can't do it. The best way to do things, we got told in my own GP the other day, you got to go to a new app. I tried to get this new app downloaded and it just near impossible. I use the NHS app for all my medication. It's brilliant, but we can't use that for booking GP appointments. So I think later on in the year, we've got to get you in again to look at more detail on different GP practices and what ones are performing. Are big GP practices the best thing forward? I was in a lovely small Studford one, now joined with Woodsend and others, and it doesn't seem as cosy now. So I'm just wondering, what's people's views on that? Are you seeing the same doctor all the time? People like seeing the same doctor or the older people. Sometimes you go and you don't even know who it is. So they're things that we have to look at going forward and probably get you in again. I think the information is very, very useful, but it doesn't tell us enough information at the moment.
Thanks. I'll just come back quickly on that. Yeah, you're absolutely right. And I think this is the first time we've had this level of data in general practice. So it's really about how we use it. The appointment data I gave you earlier, at the moment I can't break that down any more than it is, which is such a shame. But what the dashboard does is everything that you've just said gives us the ability to look into it in that detail and really drill down to where the issues are and try and put those mitigations in place.
One thing that we find is that, and it's about stopping people ending up in hospital, of course, because once they're in the hospital system, the amount of money it costs, and then they come around in that revolving door syndrome, is a lot of people won't go to hospital if they can make the appointment in the first place. So how do we know who the people that are not getting in touch with it? What are you doing to find out who these people are? Why is, sorry Lee, Mr. Duffy not coming to see us? He's 82 years old, never seen us. Is there an issue with him? And when you go and see him, you think, God, you're going to see a doctor soon. What are we doing to try to look at that?
So practices do know who their population are that they should be making sure that they're touching base with. So whether that's because you've got a long-term condition or it happens to be your age, the point around the way we're trying to work around releasing time to care is that it's not just that, stampede at 8 o'clock in the morning and you're just working. It's having that thought time. Because I think it is hard in general practice, actually, to be fair. And like I said, they feel very criticised. But even if there's nothing wrong with me, but I happen to be of an age whereby somebody needs to check in on me, the idea behind the way we were trying to work is that call takes place just to check that Kieran's fine. So it's a really difficult one around seeing the same person all of the time. I'm not sure I've actually ever seen my GP, I have to say. And I do have a long-term condition, but that's fine because if I needed them, they were there. I'm happy to see other people. But because general practice does work in a different way now, and if you go to some of our bigger practices, they have big staff. They have lots of people with different skills, paramedics, pharmacists, all sorts of individuals. But I think it's just trying to be as local as we possibly can, so that practices know their patients, see their patients, talk to their patients, so that at the point that their patients need something from them, it's easier. I'm the same with the app. I use it. I like it. My husband hates it. It's just because he can't apply himself. That's his, he's tried to use it once and it didn't work. And it's the same thing with trying to get through on the telephone. I tried once, it didn't work. And we do have to make sure access is there so we can sort of myth bust a little bit as well. Because, of course, we've got Corby down the road, we've got Kettering down the road, the lights are always on, the doors are open, and so therefore, and that's absolutely fine. But I think there is a really big part for general practice to play in this, and we want to get them back into that. And the richness of the data that we have, because prior to this, it's their data. It's actually, even as an ICB, it was always very difficult to get, that we use it in a positive way, so it's not punitive, it's not a stick to sort of beat people with. It's to say, we've got an issue here, let's try and work it out together and move forward, and then that's a different conversation. So trying to use it positively, because it's hard enough in the NHS. We don't need to make it worse for people. Thanks.
Thank you, Eileen. We have Lee next, Councillor Duffy next, and then Councillor McLean afterwards.
If I'm understanding correctly, our Integrated Care Board covers the whole of North Hampshire. Now that obviously embraces 2 unitary councils. I just wondered how, if you look at the national stats, do you think things are improving because of central government policies, or do you think that unitary and county councils can do things that improve certain areas in your care board? Because it would be interesting for us to know that a county council up north is doing something that's improved their stats that we could learn from.
It's a really, really good question, and I think a lot of what you're seeing in terms of the discussion we've just had about NHS app and online consultations and different model of general practice has come from policy change, and I think a lot of the differences are, I suppose, how each ICB has implemented those differences. So when Eileen was talking about phones just now, I immediately think around the fact that in Northamptonshire we had so many practices that were still on analogue telephone lines, and over the last 3 years the funding has come down to switch those to cloud-based telephony. If a system already had all of that in place, they got no funding, no support, because that change had already happened. That's a really positive thing. The investment on the digital side, the investment on online consultations, again, that's been something driven in the last sort of 4 or 5 years. In terms of the differences from an ICB perspective, it's really hard, because I almost feel like the national survey is probably a study in sociology as much as anything else. But I think that the work that Eileen's described in terms of neighbourhoods, that's going above and beyond kind of what the core contract is asking for. And I think that's the point of difference that ICBs can look to do. And as Eileen has already said, it involves significant investment and a big decision for an ICB to make. But it's the main area of point of difference, I suppose, that an ICB can add to what is essentially the core general medical services offer that comes via that contract.
Yeah, I presume that the boundaries of the ICB, although they might be fixed on a map, people-wise, I presume people from 5 miles outside might be coming to a practice inside. Do you break that down at all? Do you know whether the figures for North Hampshire ICB, how many people are in Northamptonshire that we represent, or are people coming in from surrounding counties? So that 5 million appointments might not be, although it's in our ICB, it might only be 4.5 million people from
in theory, they should largely, 99.9%, come from both unitaries, because the practice boundaries are generally aligned to the pre-existing boundaries that I suppose you guys have as well. So, for example, there were areas that were within county a number of years ago, like Wansford, that now sit within a different patch. So there might be some, because practices have the ability to register patients from out of boundary, but I genuinely feel, and I can't back it up with data, that it's a very, very small percentage.
Thank you.
Councillor McLean.
Thank you, Chair. This may be a question for you, Eileen. Reference Councillor Pengelly's question about do we have a system that maybe flag up patients who, for a certain length of time, don't seem to be coming to the surgery or making appointments, although they've actually got, maybe sort of general health conditions which really need to be seen to?
yes, GP systems will flag that.
And just a follow-up question. Just one which is sort of a little bit right field here. The availability of blood tests at the moment can be quite difficult for some people because, you know, they do a blood test and the GP says you need a blood test and they go in the system. And although my neighbour may not have a car to be able to get there, she's offered one. I'm in Kettering, she's offered one in Corby. It just seems to be a bit of a hit and a miss. I mean, myself, I was offered one as well, and it was quite a time away and day away. And I just happened to ring up one day and they said, well, you can have one tomorrow because one was cancelled, but obviously that was just a bit of luck. But it generally seems to be a problem. Thanks, Chair.
So hopefully in the coming year, we'll be looking at blood-taking services, phlebotomy, across the whole of the county. It has been problematic because, of course, once upon a time, you'd sit in your general practice and somebody would just take blood out of your arm and that'd be that. And that still happens. But with the amount of blood taking that now goes on, I think it's about 800,000 appointments a year. Even with our 65 general practices, just wouldn't be able to cope with that. So then, of course, you've got centres like Corby, and they have helped enormously. We'll be looking at all of that, not least because some of our blood-taking services are provided by Northamptonshire hospitals, and they're undergoing some changes themselves, which will mean that we will have to look at that. It has improved in terms of local access. I go on it frequently to have a look because I have my bloods taken locally as well. And it certainly, I think it got very tricky, if I'm honest, about this time last year. Things have improved, not least because there's been quite a lot of capacity that's come on around the Corby area at the site in the CDC and the diagnostic unit. So it's not a straightforward one because it's a high demand service. General practice have changed their views on how they wish to proceed with that. It doesn't help. It doesn't help you as a patient if you've got mobility issues or if you've got transport issues, and you might have to go a couple of miles down the road to get a blood test. I think at least there is availability now. It's not perfect for everybody, but it's something that's very much on our agenda, and we hope we will get round to having a look at it this year because I think it's something that comes up frequently. And as I said, Northamptonshire hospitals are changing what they're providing, and so therefore we're going to have a proper local solution that meets the needs of our patients and also involves general practice and the other sites where I'm being slightly cryptic because it's a really contentious issue with our general practitioners actually, so we need to bottom that out with them around the cost of it, availability of it and all that, and all those things that go along with the volume that's needed now in order to make sure that the services are comprehensive.
Yeah, just a quick one. I mean, was there a problem with staffing for phlebotomists and stuff like that? Did the staff levels go down at any time? Thank you.
Not overall, but it's. I know that there have been some staffing issues out in Isbrook, for example, that UHN, the Northamptonshire hospitals provide. So it's not without its difficulty. If you've got a small service, one person's on holiday, one person's off sick, you've got a really fragile service. So it's looking at those sort of things in the round to make sure that we just have enough to go around. Everybody, I think, all health services, and I'm sure it's the same for your services, there are peaks and troughs in terms of sickness. That October bulge that we talk about when all the respiratory conditions come on, there are staff within that as well. So we try and manage things. Practices try and manage it. The blood-taking centres try and manage it. But I think, like many services, they come under pressure if they have particularly high sickness at that point.
Thank you. I mean, I think that Councillor McLean raised a good point, something that we are hearing from one or two people that they're having difficulties with the phlebotomy service, and it's really good to hear that it's something that's going to be looked at. I wonder if we could make a recommendation that we could bring back to the Health Scrutiny Committee, maybe, I mean, what's going to be reasonable in a year's time, maybe to hear about, how that work, what it's shown, what improvements have been made, or, what recommendations the ICB has made on that. Do you think that's something we could maybe bring back?
Yeah, would you like to propose that? Seconded. Let's go to a vote. 4? Unanimous? Okay, we'll add that to the recommendations. Passed. Any other speakers? Councillor Geary?
Coming back to the utilisation fund, £102 million. I presume if it's all used by all the practices, in terms of putting that into perspective, what kind of outputs are you looking to get, and how will they be measured? Because that's a lot of money to spend.
Yeah, so I suppose the first thing I should say is that's the national pot, the £102 million. So apologies, that wasn't clear. So we would get a proportion of that. But in terms of the outputs, what we're hoping to see is we've enabled 20 practices to increase clinical space to support an increase in activity and clinical offering within the practice. So what we'd like to see, and again the data is hopefully going to help us with that moving forward, is that is a practice that's offering more services, whether that's a different services that general practice hasn't traditionally been offering, or additional GP appointments remains to be seen. But I think it's one of the few things where we should be able to see within a number of months a real benefit of the additional space.
And to put that into perspective, how much money is spent on practices in the country? If it's £102 million for this project, how much of those practices spending per annum is obviously into billions?
Well, I don't know, because I think the issue is capital isn't always available, and practices may need to make changes, but it's not necessarily something that's affordable. I don't know if it'd be in the billions, and I think all practices would have a shopping list of something they'd want to do if the money was available. But it's probably an inexpensive change, to be honest. I mean, in terms of profiling it down from a Northamptonshire perspective, the 102 million broken down by the share that Northamptonshire got, and again, I would expect that Northamptonshire got a bigger share because of the number of applications that ended up being approved. They're small-scale changes that we like to think will have quite big benefits, if that makes sense.
It makes sense. It comes down again to me being quite brutal about this in terms of, okay, Northamptonshire has 1 or 2% of the UK population. You put that in, invest it into these organisations in labour, etc., etc., etc. What is the additional change that makes? And then if you look back on that and use different methods to get the same output, is that the best way to do it? That's what I'm coming back to, is it from that side. So it'd be interesting if there's any measure of that comes up.
Yeah, and as I say, I think we would have the data to either be able to support that or suggest that we haven't seen the changes. But I also think that capital investment is quite important, and it's unfortunately, if it's something that slips, you start to see a degradation in the estate, I suppose, and that's a concern. So I think every opportunity we get for that capital, it's almost a case of if Northamptonshire doesn't take it, somebody else will, you know. And this was definitely one of these where we grabbed it with both hands and said, we'll have that, thank you very much. You're right, what we want to see is something. We want to see something at the end of it.
To measure that, to say, we learn from our experiences, just as these local practitioners hopefully will learn from the experience that you're able to share, and I think it's a good idea intuitively, but it's great to measure that, to then to go back to government and say, this has worked, here's what it's done, don't stop the project because you've got a new toy to play with, come back and use this again.
Great.
Thank you.
Thank you, Councillor Geary. Any other questions from the members? No? And you managed to answer all the questions that I had as well, so I don't have any either. We'll move on to the holding recommendations. We've already had one recommendation that we've passed already. We have a recommendation that the ICB provides a further update to the committee within 12 months, which I think you mentioned earlier, Councillor Pengelly, on trends in GP access and appointment availability, including how increased activity is improving with patient experience. Do we want to, would anybody like to propose that recommendation? Do we want to come back again in 12 months? Propose, seconded, and let's move to a vote. Yes? Unanimous, fantastic. That one passes. The second one is regarding reducing variation and sharing good practice, that a future report outlines how unwarranted variation between practices is being addressed, including examples of improvement support and learning shared across primary care networks. Do I have a proposer for that recommendation? Councillor McLean, seconder. Councillor Duffy, yes? That passes. And the third one is regarding evaluation of new models of care. The recommendation is that the committee receives an evaluation of the Wellingborough Neighbourhood Early Innovator site once established, setting out outcomes, patient feedback, and wider lessons for rollout. Proposer? Councillor Howes, seconder. Councillor Harrison? Yes? Is that your hand, Chris? Yeah. Let's do the hands again.
Yeah,
a little bit higher so I can see. There we go. Unanimous. Thank you. Are there any other recommendations that the committee would like to make? No? Fantastic. What we'll do next then is we'll move on to the next item on the agenda. I think you're all staying for this one, aren't you? Does anybody need to leave? Lewis, thank you for coming along. Hopefully we'll see you again. You're just moving chairs. You're just moving seats. You put your hand up at the wrong time. All right, Lewis, thank you. We'll move to your report, which is on page 25 of the agenda. Over to you.
Perfect. Yeah, wasn't escaping just yet. So evening, everyone. So what I've done is just pulled together a bit of an update just in terms of, I suppose, what's happened in the past in regards to dentistry and I guess what we've looked to introduce to further improve access. So next slide, please. So just to give a bit of background, there was an oral health needs assessment which took place, and that was across the East Midlands, but also including Northamptonshire, which helped us to kind of understand, I suppose, what the picture of dentistry looked like, and I think that was quite important because I think it was the first one post-COVID. A lot of the information on the screen you'd likely be aware of, but I think just to pick out, the Northamptonshire was particularly affected from handbacks, contract handbacks following COVID. So as you can see, 5 contract terminations between 2020 and 2023, just under 50,000 units of dental activity handed back, which did have quite an impact obviously on dental access. The largest, as you can see, with West only seen an 18% decrease in comparison to 25% in the North. And the recommendation from that piece of work was the priority order of future commissioning, which ranked North Northamptonshire ahead of West Northamptonshire. Next slide, please. So just to give a bit of an overview in terms of dentistry, so currently we have 37 contracts, just under 500,000 units of dental activity commissioned. We do have 3 8-to-8 services in North Northamptonshire, which are open 365 days a year. You can see, as of December, around just under, around 50% of the activity had been delivered. But just to note, there was a bit of an issue in terms of dental claims. That's around 5 weeks behind, so that figure is likely to be slightly higher. Compared to last year, so around 76% of the contract was delivered, but since post-COVID, that percentage delivery has steadily increased, roughly around 2 to 3% per year, and tracking to deliver more than that 76% in this year as well. Also orthodontics, there's 6 contracts across Northamptonshire. With orthodontics, generally, the full contracts are delivered. As you can see there, last year, 103% was delivered. To add a bit of context, I suppose, to the national picture, as you can see there on the table, the comparison for adult access is lower than the national average, but in children it's higher. But overall, it's slightly lower than the national average. Next slide, please. So as I've mentioned, there were a number of obviously contract handbacks previously in recent years, but in order to further improve dental access, we've been doing, or the team have been working on a number of different ways to improve access and get it back, and I suppose higher than what it was before. So measures like the Golden Hello Recruitment Incentive Scheme, which look to introduce more workforce into areas identified as high priorities in terms of deprivation. So 4 places currently live. Increasing the minimum UDA rate, so the finance that a dental provider would get for delivering dental activity, that was increased. So any provider that would have normally got less than £28, that was increased. It didn't have so much of an effect for Northamptonshire contracts because the UDA rate in Northamptonshire is generally relatively high. I think there was only, like I say, 3 providers that benefited from that. We've also offered the 110% overperformance scheme to all dental providers for the past 2 years in Northamptonshire. So in the north, that's seen an additional around 17,000 UDAs awarded this year to be delivered. I won't go through all of these, but I'll just pick out some of the other key ones. I suppose looking to also increase the activity that some providers deliver. So we've also allocated just under 21,000 UDAs to existing providers, and we've also recently awarded a new contract in Wellingborough, which is looking to mobilise in Q1 of the next financial year, which will be really good news. Next slide, please. As you might be aware, there's a national focus on urgent care, and at the start of this year, the government announced individual targets for each ICB to achieve in terms of urgent care delivery. And as you can see there, Northamptonshire, where their target was 17,862 additional appointments. We were able to commission 18,088, and that figure's actually rose now to just under 20,000, which is really good news. And additionally, in part of the stage 2 of the scheme, we also commissioned an additional 1,989 courses of treatment to be completed from existing providers as well. Next slide, please. A big contractual change that came into effect in June 2023 was around contract rebasing. So this is the first year where we've looked to implement this change, and really what that's helped us do is to take activity from providers who generally or haven't delivered their contract for the past 3 years, and we're now able to extract that funding from those providers to reinvest into other services of providers that can deliver contracts, which will have a significant effect from the next year when we're able to recommission that activity. So as you can see there, 40,000 UDAs have been taken from contracts who weren't delivering that activity and haven't for the past 3 years, which we'll look to deliver next year. Next slide, please. And I think this is one of my last slides, but there's also, and you may have seen, further dental reform that's been announced that will come into effect from April 2026. And I guess the key points to pick out around urgent care and the focus on urgent care and that being put into contracts. I think around 9% that's going to be put into individual existing contracts for urgent care, and also the revision around patient recalls with the 12 to 24 months for adults, because not necessarily people don't need to come every 6 months, which again will have an impact on dental access. Next slide, please. That's my last slide. Thank you.
Thank you, Lewis. You can go home now. No, joking, please don't. I'll open up the floor now to members for questions and comments. No questions?
I've got a question.
Councillor McLean?
Yeah, just looking at the figures here for Northamptonshire, it says adults population assessing NHS dentistry 57,000 out of a total population of 283,000. Don't you find that shocking? Or all these other people got really good teeth? Where are they going for the dentistry?
Hi. Traditionally, only about 50% of the population actually choose to access a dentist unless they're in severe pain. A lot of them would rather not, due to the cost of it, because they have to pay for their dentistry, but also because they're anxious about going to the dentist. So although it is shocking, and we would rather it was much more, it's not quite as shocking as if you were expecting it to be 100% in the first place. There's a problem with access, which has restricted that. But the 700,000 urgent care appointments that are a national incentive, they've incentivised practices to provide those appointments have gone unused across the whole country. Less than 50% of those appointments have gone unused because people don't want them, don't need them. So it's a difficult scenario because it's patients' choice to go. They're not registered with the dentist. There's no registration, so they have nobody recalling them, telling them they need to come. It's all off their own backs, and if they don't want to go, then they don't turn up.
Yeah, I understand what you're saying there. You say that 50%, but here it's the access rate is only down at 20%. And when you consider that, as far as I know, those of the population who are in government assistance don't have to pay anything. It looks like they just don't turn up at all unless they've got an emergency. Is that true?
That's true. Yeah.
Thank you, Chair.
Thank you. We'll go to Councillor Howes next, and then I've got you after Councillor.
Thanks, Chair. I just wanted to seek some clarification over what exactly the 52.9% or potentially higher, what that means. You said that people basically don't take them up. So is that there's, let's say, 100 available appointments throughout the course of a year and only 52 are taken, or is that the actual dentists themselves not delivering the full 100? Does that make sense?
Yeah, so the way that urgent care works is that practices have specific sessions which they say they will be open offering urgent care from, say, 9 till 12 p.m. What will happen is if a patient has they need urgent treatment, they will call 111 or the practice directly, and they should have that slot available. But what is happening is what's been commissioned, that session between 9 till 12, for example, there isn't a demand for that, so that session's remaining unused, if that's answering your question.
Yeah, it does, thank you. So how does that link in then with incentivising dentists? So because surely the incentive needs to be for the patients, not the dentist, to fulfil the contract, or I got this completely wrong?
So traditionally, in the existing contract, but before this incentive scheme was put in place, if a patient didn't turn up to the practice for an appointment, the dentist didn't get paid.
Right.
So dentists are obviously running a business, have costs, overheads, etc. They got into the situation where they stopped offering those appointments because they wouldn't get paid for them. So the incentive is that they're being paid an extra to actually book in sessions instead. So if the patients didn't turn up, they wouldn't necessarily lose their income.
So they do get paid for the 48% that they don't actually do dentistry work for?
They may get paid for it. They've already been paid for it, but it hasn't. So the government initiative said that these 700,000 were required and made everybody do them. It's not actually been announced yet whether they will actually let them keep the money that they were given for it, or whether they will take it back off them.
Right, okay, because
they've got
the point I was
option
going
to do
down is
that.
it seems a bit silly to pay them and then pay them again for doing it. That was where I was going with it. But if there's a potential that they might not be getting paid for it, then that makes more sense.
Thank you. Councillor Pengilly?
Yeah, we get into the danger of looking at the small part of people not turning up as being the big issue with dentistry, and it's not. We have You said, and I think it was good that the government put the target on for 17,900 or whatever new appointments, and you said we've got 18,000 and so often. Was that enough? Did we need more than that? Should it have been 25,000 or what should have that figure been? Because I see on social media and people phoning me up all the time that people can't see dentists. There's also, and I don't know what a locum dentist is called, but I know today my wife went to go to the dentist and she got told, sorry, the main dentist is off, we can't get another dentist to fill in, so we've got to cancel your appointment. And that's happening time and time again in North Hampshire because we haven't got enough dentists. And all the schemes that we've got out there to try to get more dentists in, but this is a major, major issue. And the big thing is how many children aren't being treated for dentistry, because that's the main point, especially children like me eating sweets or whatever when they start losing teeth. If that isn't taken on board, that becomes a big, big health issue going forward. So there's a lot more we've got to look into this, on this. I think the work you've done has been absolutely brilliant because we've seen the changes, so I welcome that. But there's a lot more to do, isn't there?
Yeah, definitely. It's the start of something, and we're actually seeing improvements in the workforce, whereas 5 years ago we hardly had a dental workforce. So the changes to the contract, some of the incentives, just the number of dentists that's being trained, the use of skill mix means that things are getting better, but it's a slow burn. Hopefully there's more, well, there are more changes to the contract which will again incentivise people to work in the NHS. The problem is that in this country we have enough dentists, but they don't choose to work in the NHS, they work privately because it's so easy. It's different from GPs, where private GPs are a rarity. Private dentists are...
Things have changed a little bit lately, that there wasn't enough private practices as well. So I was in Oasis, which was on, you know which one Oasis is, where is it, Leas, Priors Hall, Oakley Vale, that just closed overnight and we all got told there was no dentist to go to. We had nowhere to go. And I know people from Corby that are going to Market Harbour and Northampton for the dental treatment, and we've got to get, and I'm sorry for talking about Corby, that's what I'm talking about. So I've seen massive improvements, and I go into a lot of dentists around and I can see the staff work really, really hard, but there's still a little bit more work to do on getting things right. And that target that I asked for earlier about the 18,000, what should that be? Where would we be looking at? It's a question you asked, that it's down to 25%. We should be looking for the 50%, shouldn't we? That we should be going that bit higher.
So before I forget to answer that one this time, the 18,000 appointments were not used. About 50% of them were taken up. So if you look at that, you could say actually only half of them were necessary. But we know that there's a population of patients who either choose not to until they want to, so you have to be ready to look after them when they need it. And then there's others who have chosen to gone privately. The Oasis were part of a corporate, and it was a corporate decision after COVID to get rid of practices that were poorly performing, and they handed back something like 63 contracts across the country. So we've got, it's complicated, isn't it? It's not a simple give appointments and people will turn up. It doesn't work like that.
Councillor McLean.
Thank you, Chair. I mean, we seem to be in a catch-22 situation here, well, probably for a long time, actually, with dentistry, that dentists are going private because they're not, as far as they're concerned, making enough funds to run their practice. And at the same time, on TV, we have many, many adverts about use this toothbrush, this electric toothbrush, it's fantastic, and use this kind of toothpaste because it's great. But we don't seem to have a campaign about getting people to look after their teeth and brush their teeth. I mean, I know these things cost money, and obviously the companies that advertise the toothbrushes and the toothpaste are the ones that are making the money, but we need to have a counter campaign even on television, that the government should be able to get the TV companies to give reduced rates for this, to be able to say to people, you need to look after your teeth, and getting down to the children as well. I know we have campaigns with the children where in schools now they're teaching them to brush their teeth and have a toothbrush and stuff like that. And obviously that's the responsibility of the parents, but sometimes that doesn't happen. So we need to have some sort of programme, at least, to get people to be aware of the value of looking after their teeth. Thank you. Thanks, Chair.
There are programs out there. There's a lot of the toothbrushing, the toothpaste sales programs are part of, are obviously encouraged by the government to be there. There's also things like the sugar tax, the fact that your sweets are more expensive now than they... because it's thought that obviously if you reduce the amount of sugar that would make you wouldn't need dentists if you, or not so many anyway. So there are campaigns and things, and the use of skill mix, and in the changes in the contract, the legislation is changing. So dental nurses will be able to apply fluoride to children in the practices, and will get 0.6 of a UDA for doing it, which means that more patients that need fluoride or extra fluoride will have. So there are things being done to do it, but like I say, you won't see changes overnight. It'll be in years to come when you'll notice that actually the rates of children requiring GAs for extractions and things like that will be reduced, but it won't be for a while because it'll take ages to seek through.
Thank you. We'll go to Councillor Duffy and then Councillor Geary afterwards.
Thank you, Chair. Going back to the 18,000 extra appointments and only 50% of them being taken up, how are those extra appointments advertised or publicised or made available to the public? In that, if I phone my dentist and my dentist says, Lee, you can't get an appointment for 2 months, is there a pool of appointments somewhere that I can access at other dentists?
Yeah, so there is, that's really loud this time, sorry. 111 is a system that you use they will link you to a practice and book you an appointment or give you the means to book an appointment. So would my dentist direct me there? No, they won't. They're supposed to tell you that you can go to 111 if you need an appointment. We also had campaigns in the East Midlands. We had TV campaigns and everywhere, GPs, everywhere we could think of that we thought would be a good idea to advertise that these appointments were available. We did, but it doesn't mean you actually get to everybody, or when they need it, they remember what they saw or what they heard at the first place. A lot of people will attend A&E rather than go to the dentist because they see it as cheaper because they don't have to pay to go and see or to go to their doctors or wherever. So yeah, it's difficult. You can't drag them, you can't make them. But over time, hopefully they get the message.
But potentially that 50% that isn't utilised, that custom is out there somewhere. They just don't know that it's available to them.
Yeah.
Okay.
So, it sounds a good idea to spend some money to encourage the group of people that currently don't use the service available. So let's say that I'm in health and I have £100 million to invest in increasing usage. My second question is going to be, if I gave you this funding, what benefit financially would that give? Yes, there'll be health benefits, but is there a financial metric that you could come back to me and say that for every pound I invested in increasing the capacity, you could bring back to the economy, people's health, £5?
I'm sure there is somewhere, but I'm a dentist. I don't know what it is. You don't know?
Not the exact figure, but what I was going to say, I suppose the 18,000 figure is for urgent care. So for the reason why a lot of the appointments aren't taken up is because they have to be urgent care. It's not general dental access, which is part of the reason. So I think as you can see, a lot of our other focuses have been around improving that general access, which is more difficult to get. Yeah. It's the urgent care which has been obviously mandated to be delivered, but there isn't that demand for urgent care because it obviously has to be urgent kind of thing, if that makes sense. But I suppose the benefit of having better access to general dentistry is that then you don't need the urgent care. So it's almost a catch-22. If you prove general access, you'll need less urgent care, then you'll have less people turning up at A&E, and then that will have obviously benefits for keeping hospital beds free and things like that. So it does have quite big impacts.
Thank you, Chair. Is there a general reason why patients are dropped from an NHS dentist list?
There isn't anything. There isn't a dental list. They stopped in 2006 or even before then. So you're not, a dentist only is contracted. When you go to the dentist for a checkup, you enter a contract with that dentist, and the course of treatment that is started at that point, they are required to complete that course of treatment for you. But as soon as that course of treatment's finished, they don't have to see you again. People build relationships and sort of assume that they're on a list, but there isn't a list. I think the lists were got rid of years ago because it became, they weren't politically beneficial to the government at the time because it showed how few people were registered with a dentist. So they got rid of them. So the access was theoretically available to more people because you weren't aligned to a dentist.
Yeah, I think maybe my question maybe came out wrong there. It was, people who are removed from NHS dentistry and asked to go private with it.
Again, it's just the practice's decision. It's a business decision. They tend to keep patients who attend regularly and attend well and pay their bills. And if you go irregularly, they probably aren't quite so interested in you because you're a higher risk of not turning up and actually costing the money rather than making the money. So it's a business at the end of the day.
I mean, you know what's going to come next, don't you? Me.
Sorry.
I was dropped and I had always attended appointments and I never needed anything done. And I was taken off of it.
Yeah, I won't comment on that, but it's quite a complex and it's not normally my decision, certainly wasn't in your case.
Yeah, but they're quite happy for me to be on DEN plan.
Councillor Pengeli, go ahead.
And you might not have an answer to this, and this to do with the cosmetic surgery, which people go to Turkey and things like that. There's nothing coming out from the government or anybody. I know so many people that have been going over to Turkey to get dental treatment. Is it safe? Is it not safe? Do we know? Have we got any figures on it? You hear about things when people go for breast enlargements or breast reductions or whatever, and there's a lot of dangers to do with that. Is there anything coming back from the likes of the teeth situation? I know so many lads and lassies that have gone for it, and I just wonder, they're saying it's the best treatment they've ever had, it's absolutely brilliant, they're treated like kings and whatever, but is there anything out there for public health or whatever, or there's just nothing there?
Time will tell.
Yeah, time will tell. That's worrying though, isn't it?
Yeah.
Yeah.
Yeah. Councillor McLean, go ahead, and then I'll go next.
Another question here is, I notice on the list there the dentists are, is it new dentists that are offered the golden hello? And if they are offered this golden hello, how long does it tie them to, let's say, working for the government? Thank you, Chair.
It's not necessarily new dentists, it's dentists moving to an area. So it's to try and encourage people into the more rural areas or the areas that are under-resourced. I think the latest scheme ties them in for 3 years. 2 years?
No, you're right.
2 years.
No, it's 3 years.
It is 3 years. It ties them into 3 years. But it's really, really difficult to actually tie anyone into a contract. they're self-employed, so there's no, and if they have good enough reasons to leave, family circumstances, something like that, they will just leave. They do have to pay back the money if they leave, if they haven't already spent it.
Yeah, thank you for that. I mean, we've got loads of questions here, but I think actually when we look at the whole dentistry situation, I really don't really see an answer to much of it. Thank you, Chair.
Thank you, Councillor McLean. I want to ask about the upcoming reforms in April about the NHS dental contracts. How is that going to impact dental treatment, and are you prepared for it?
Are we prepared for this as the ICB? They were only announced about 2 weeks ago, and they have to be put in place. And there isn't a lot of guidance as to actually what the detail is. So we've had very little time to prepare ourselves. I wouldn't like to say we're not prepared, because we always like to be prepared, but it will be challenging to get everything out. I suspect some things will be delayed. There's also no new money, so it's fiddling with the contract. It's giving the dentists, allowing them to do less work and to be paid the same amount of money, to work differently and be paid the same amount of money, not actually being paid more money. So it's not necessarily popular with the dentists, because it doesn't. NHS dentistry, again, isn't bringing more money into the practices. And the option of private is appealing still.
So you found out a couple of weeks ago, and this is due to come into effect in April. So based on what you've looked on so far, do you think it will have an impact? And it sounds like from your answer just there, it likely will.
I think it will have an impact. I think everyone's a little bit shocked and still thinking about it, and the practice is still considering. I've heard of, not particularly in our area, but in other areas of the country, where practices are actually thinking of stepping away from the NHS, because it's another sort of, we've been waiting for this, we've been hoping, and this is what we're getting, and it's just more work and more the same. And so it could be very difficult, and put us in a very difficult situation if people do walk away from the contracts because of it, because that won't help access.
Thank you. Sounds pretty concerning. Any other questions? Go ahead, Councillor Duffy.
Yeah, can I just ask my final question? Back when I went to school, we had dentists come in to school to do checks. Does that still happen, and at what stages? I think it was annually when I was at school, but do children get introduced to dentistry at school?
They get introduced to some dentistry at school through the curriculum. There's in the very early curriculum, there is a part when they're introduced to general healthcare and dentistry for part of that. There are no school dentists anymore. They stopped quite a while ago, just as things change. There is unlikely to be a resurgence, because it's recognised that although that's a screening exercise, you still have to get them into a dentist to be seen. So it's easier and better to actually just have a general dentist actually seeing the children with their parents. There's a lot more issues these days around consent for those appointments if they were done at school. So yeah, change of model. They're now seeing a general dentist instead.
Is there a correlation that you can show that if a child starts seeing a dentist at 3, even if it's just for checkups or a young age, that there's a financial benefit later on in life, they'll need less treatment? Is there a marker that you can show that?
I think it's a complex. It's not a guarantee, because obviously you only see a dentist every 6 months or once a year. It depends what happens every day at home. So with your toothbrushing and whether you can afford toothbrushes and toothpaste and things like that. So it can't be a bad thing to see a dentist, but it's not a guarantee that actually it will guarantee you that you won't have problems in the future, even if you start at 3.
Thank you.
Chair, am I able just to come in on that in terms
Of course, go ahead.
In local authority public health, teams do have some responsibilities to commission oral health improvement programmes. So some of those funded services at the moment are focused on supervised toothbrushing schemes in schools and early year settings, with that aim of introducing children to toothbrushing. I think there is that the aim of that is building, I guess, where there hasn't been that generational norm of brushing teeth. There is evidence that starting that at a young age does support that break in that cycle. So at the moment, there are supervised toothbrushing schemes running in the areas with the poorest oral health outcomes, so it's data-driven in terms of where they are. There's currently around 30 early year settings signed up to some of those schemes, and there's also a national supervised toothbrushing programme in primary schools, so that targets the most 20% deprived communities. So I think the latest information we have that we've got around 6 schools actively participating in that, and a further 4 schools in the early stages of joining that programme. And there's training going out to schools available through the year. So I think they've recently received notification that programme's been extended for a further 3 years from April 2026. So there is activity in that area in terms of introducing at school that young age and those consistent messages. There's also some work that public health do with food banks and food vulnerable communities, so that involves distributing the sort of toothbrushing packs and promotional and informational materials for oral health, so that vulnerable people and families can have access to toothpaste and toothbrushes.
Thanks for adding that in, Pippa. Just a question on that, if I may. How long have the toothbrushing schemes been in place? And I suppose, have they been in place long enough for us to see any long-term data, I suppose? So if you've gone into a school, you've done these initiatives, are we seeing those children go on and come back to dentists with teeth issues, or are we seeing any reductions anywhere? Or is it too soon?
I think I'll have to come back to you on when they started. I've got the information in terms of what's running at the moment and when they run to. Some of that funding is non-recurrent, so it is money that comes just for the year, but we can take away to come back and confirm how long they've been running.
Dennis?
Just to follow up on the Chair's question there, you were saying about the funding. How much is the funding anyway that's been supporting this?
If I could also take that one away to come back to you and confirm. Thanks.
Thank you very much, Chair.
Members, any other comments or questions? No? Thank you. What we'll do now then is we'll move into the recommendations again. So the first one we have is regarding monitoring dental access recovery. And this one states that the ICB provides a further update to the committee within 12 months on progress in restoring dental access to pre-pandemic levels, including adult and child access rates in Northamptonshire. Would anyone like to propose that? Councillor McLean, seconder. Councillor Pengelly. Move to a vote. Yes. Unanimous? Sorry?
Unanimous, Chair.
Unanimous. Second recommendation is that a future report evaluates the impact of workforce incentives, UDA uplifts and new contracts on increasing NHS dental capacity and reducing inequalities in access. Proposer? Councillor McLean, seconder. Councillor Howes. Let's move to a vote. Unanimous again. This is a good evening. And then the final one is that the committee receives an update during 26-27 on the local implementation and early impact of national NHS dental contract reforms, including urgent care provision and complex care pathways. Proposed by Councillor Duffy, seconded by Councillor Geary. Let's move to the vote. And Unanimous again. Thank you. I'd like to thank the members from the ICB for coming along and presenting and answering our questions. Much appreciated. Thank you to the members for another respectful, orderly debate. I'll see you all in the next one. Thanks for coming. Hope you all get home safe. Not yet, not yet. I've missed an item on the agenda. Thank you. This is for members, the final item, so you are free to go still. The members, you have to stay. We've got one more item, which is the forward work plan, and I'd just like to ask members to confirm that you have considered the health scrutiny work plan for 25-26. Yep. Any comments or questions on the forward work plan? No? Lovely. Then in that case, I will now bring this meeting to a close. Thank you. Kieran, can I borrow you before you go?